take a second, think about your passion. This is a thinking exercise, you don't need this. Okay? Who would you be without this passion? Who would you be if the opportunities before you were stripped from you by a system you did not elect to be a part of? Our study here, as you can now see, right, aims to target graduates of the American foster care system, those who have developed Cptsd, or complex post-traumatic stress disorder, as a result of childhood neglect, in addition to compounded traumas. So we can go to the next slide. We are going to utilize a coupled approach of neuromodulation methods, Tibus and DBS, as we learned a lot about this week, to target individualized DBS treatments for those suffering PTSD with developing brains. By targeting graduates of the American foster care system, we are making sure we can try to give them back the life that they should be leading. They will have had exhausted all non-invasive therapeutic measures to be eligible for this study, with nowhere left to turn but our research and our, yes, invasive, but hopefully successful approach as it is individualized.
Okay. So this meditation will be using Tibus to help identify the hyper or hypoarousal of the basolateral amygdala. And this will hopefully help us use DBS better, in a way. So the reason why we're using foster care graduates is basically because 90% of kids in the foster care system report seeing trauma or experience some type of trauma. And then 50% of those kids reported seeing 4 different types of trauma. And then we want to help these foster care graduates with helping with cognitive control, conflict resolution, and emotional attention. We want to be able to use VBC as a way of treatment for psychological disorders if needed.
Okay, so some of you might know what PTSD is, but you also might not know what Cptsd is. Well, Cptsd is complex post-traumatic stress disorder, mostly found in children, and it is a result of experiencing extenuous and repetitive amounts of trauma. Cptsd is not yet recognized by the DSM-5, but is recognized in the ICD-11 since 2018. So, what is hyperarousal and hypoarousal? Well, hyperarousal is when someone experiences, say, excessive bouts of anger, high irritability, and paranoia. Hypoarousal is when someone experiences a hard time in social situations and disassociation. So, 424,000 children are in the foster care system in America every year. I just want you guys to think about that number for a second. It's crazy, right? Okay. So, why are people in the foster care system? People are in the foster care system for many reasons, some of which are because they were we either lost their caregivers at a young age, or were removed from an abusive and or neglectful situation, or were given up by their parents. Every year, over 20,000 children age out of the foster care system, with roughly 90%, as mentioned before, of children in foster care developing some form of Cptsd or mental illness, twice the rate of war veterans. For many of them, this can be debilitating, even with normal treatments such as medication and therapy not being effective in alleviating their symptoms. That is why we have proposed the idea of DBS.
So what is DBS? Well, DBS is deep brain stimulation. It's a form of neuromodulation, and it does involve neurosurgery, and it is a very invasive procedure. Because of this, we need to stress that this study is for participants who have already tried everything they can with therapy, and this is a last resort. So, DBS, usually it is for diseases like disorder diseases, like Parkinson's and dystonia. And it also does show that there are some studies like public OCD. There is one study that suggests that PTSD can be alleviated in war veterans, but the question remains, will we be able to alleviate symptoms of PTSD when the CPTSD happened during childhood and came from childhood and has been with them from childhood. And Tibus, Transcranial Focused Ultrasound, is a non-invasive technique, and it does work with brain stimulation, and it also helps us map the brain and let us know what parts of the brain need to be, like what parts of the amygdala, which is what we're targeting, need to be hyperaroused or hypoaroused. It works by using sound waves and utilizing the physical properties of the brain user's skull to push the sound waves and have it bounce around and come back, and you can see it. Again, this is a non-invasive technique.
Okay, so due to our coupled approach, we actually are testing two hypotheses here. First, we believe we can profile one's trauma phenotype by studying their response to Tibus and seeing whether or not they respond better to stimulated or inhibited amygdala. It helps inform our next treatment of DBS, in which we will either stimulate an understimulated amygdala or the reverse, inhibit an overstimulated amygdala. Because childhood neglect often results in a hypo-aroused amygdala, which is control across our entire study, we want to control that, but you also have to realize it's not as clear-cut. We are going to have compounded traumas in our children that are going to hyper-arouse their amygdala, sending them in both directions, which is why we're individualizing our treatment. So we're going to test to see if we can profile their phenotype, and then the DBS with individualized treatment is a successful means of alleviating PTSD symptoms, specifically complex PTSD.
The sample size we are planning to use is a sample size of 12 people. 6 which will be biological males, and the other 6 will be biological females. The reason that we're doing this is so that we can study across the different sexes and how it affects each person. The age range between our patients would be 18 to 25, mostly because we still want to focus on trying the treatment on developing brains. So, in order to be eligible for this, there is a pre-screening that will be done with a clinician that will base upon 30 questions, which are meant to study and kind of measure where on the scale and how hard they are or how much PTSD they have in order to properly integrate them into the trial. So first we're going to use Tibus in order to, of course, as they explained before, determine if it's a hyperaroused or hyperaroused amygdala. And once that is done, we are implanting the device. After the device is implanted, we are having a 30-day period where it won't be active at all, mostly just because we want to make sure that our patients have recuperated from the surgery and haven't had any side effects because of it. Once that is done, half of our subjects, 3 biological males and 3 biological females, will have the device activated in order to study them across a period of 12 weeks. Once that 12 weeks are over, they will have a washout period of 10 days, and after that, they will reuse the test that we use for the pre-screening in order to evaluate where they fall now in the category of PTSD. This study is meant to be done across 18 months, so we can have a long period of time to study each group.
A really important, critical part in ensuring the integrity of our experiment are these 2 design elements: crossover controlling and double-blind evaluation. So first, crossover control. I want you to picture Group A and Group B, right? They all get the device. For ethical reasons, we are not going to promise treatment to people as a placebo and then have them not receive that. So Group A is going to receive the treatment while Group B doesn't. From there, they're going to go on a 12-week cycle, as just mentioned, Then, for a 10-day washout period, no groups will be receiving the treatment, so the neuroplasticity, for neuroplasticity reasons, of Group A. Then we're going to go into Group B receiving the treatment, with Group A not receiving the treatment. Okay? So in a sense, they are serving as their own controls. Then, double-blind evaluation is to ensure the trust in our experiment and our results. Those evaluating our patients will not know what treatment group they're in. So our psychiatrists are not going to know this patient's receiving treatment right now, this patient isn't. Okay? We're eliminating bias in that way. Those receiving the treatment actively also will not know what group they're in. So they do not know if they are currently receiving treatment or, again, not currently. Therefore, we hope to eliminate some bias, and while we can't completely eliminate a placebo, this will help us identify if there's just a really strong placebo effect that's giving us the results we hope for.
So we anticipate that the BBS with Tibus will help with the hyper and hypoarousal in the basolateral amygdala. And this will help with emotional regulation and extreme disassociation, and help with them who struggle with emotional and social situations. But this isn't a very sure treatment yet. There might be a way that this does not help them at all. But this research will still be helpful in future cases where people are using BBS for other forms of PTSD, other forms of OCD, or even just other forms of eating disorder. We also want to be able to compare the people who have hyperarousal and hypoarousal to see if there's any difference or similarities in their treatments and how it affects them in the future. And we're going to compare this research with past research about Cptsd veterans and see if there's any similarities there as well.
Of course, ethical, legal, and social implications of this study are vast. In working with such a vulnerable population, it is critical that we provide them the resources they need that we cannot assume they have access to already. This means present and future. In the present, we are going to mandate that all patients remain inpatient with us for their safety, but also so we can track their symptoms much more closely. If something were to go wrong, we want to be there for them, and we also cannot ensure our participants have ample support at home. So in giving that support, we eliminate barriers to the road to recovery. Similarly, providing comprehensive physical and mental health care, present and future, ensures, again, we eliminate obstacles to recovery. We are testing our neuromodulation methods. We are not testing who has the best support, who has the best therapist. No, we want to provide them every tool they need to lead the life they deserve. Finally, future maintenance. Whether this study is a success or not cannot risk the lives and well-being of these people who trust us to implant technology into their brains. No, we are going to ensure there is always available maintenance of these devices, whether or not our study is a success. Finally, social. As I'm sure you all already know, the recent overturning of Roe v. Wade protecting women's right to an abortion is going to have severe consequences across the country, especially for the foster care system. An already notoriously bad system is going to be overflowed with an influx of children, as it already cannot handle the current capacity it has. That means more children, less resources per child, and a greater need to find methods like this to alleviate the really, really awful disorders they leave this system with. And we hope that in starting this research now, by the time the current influx of children that we should soon see graduates the program, we'll have safe methods that we are confident can help them, ready for them upon graduation. While we hope that that is not necessary, every statistic points to this kind of research being absolutely critical to protecting America's future. We want to extend a great big thank you to everyone who's helped us get here, starting with, of course,
Dr. Giordano, Dr. Wordsman, Dr. Green and Dr. Arkin that aren't here, but still we want to thank you so much for all the knowledge and all the concepts you have given us. It's completely super needed for our study, so we completely thank you for that.
And then we also want to thank our team members, Cassidy and Yahweh, who are not with us because of illness, but we appreciate the help that they gave us when they were here.
A great big thank you to Max and Morgan for their constant energy, their organization, their jam-packed days. Thank you so much. You made this experience so completely memorable.
And we want to extend a really big thank you to our senior lead, Elena.
And finally,
And last but certainly not least, we would like to thank our fabulous audience. for sitting with through this, you know?